Hello, welcome, good morning. I'm discussing ICDs in athletes, indications, options, and return to play considerations. So the indications I'm not really going to get into. The message about indications is if there is a clinical indication for them to get an ICD, regardless of whether they're an athlete or not, then they should get an ICD, and if there is no indication, then they should not get an ICD. I gave this talk the last time we did the CME, which was in 2012 or 13, maybe? Something like that, 4 or 5 years ago, and I think it was both there was really no data at that point and it was a little bit more controversial. I think our thought processes, at least of all the speakers here today, have sort of coalesced a little bit more about allowing to play. So this is not the audience response. We'll do just to raise a hand. So I would let a patient with HCM and an ICD play basketball. So I know we sort of talked about this yesterday. There's no maybe this time. It's either yes or no. Yes? Yeah, they want to play basketball. All right, no. All right, and there's like 30% who didn't vote. So it's smattering either way. It's interesting, after the session yesterday, we were talking a little bit about the patient that John presented who was HCM. Did he have an ICD? No, he didn't have an ICD. And sort of how our thoughts had changed or not changed over time. So I actually would let someone play basketball with this, but again, with heavy counseling and education. But let's talk about this. So why even have this talk? Because of course patients shouldn't be allowed. They're at high risk of dying. You don't let someone play basketball or any other sports. But then you could also say, well, of course they should be allowed. They have an ICD. They're protected. So let's go through the limited amount of data that exists for this. So the Bethesda Conference 36, which is a dozen years old or so now, so they say that although effective for sudden death prevention and observational studies, the unique physiologic milieu associated with competitive athletic activities make the absolute reliability of ICDs in such settings unpredictable. Now, I would argue there is no absolute reliability of ICDs in any setting, and we know that. The panel asserts that the presence of an ICD should disqualify athletes from most competitive sports. So that would leave out the most would be the Class 1As would be okay. You can do your yoga. The new document that came out a couple years ago now says that participation in sports may be considered if the athlete is free of episodes of ventricular fibrillation requiring device therapy for 3 months. And I agree with that. I think that's a very reasonable plan if someone gets a shock for VF. That number one, you can be willing to allow them to play and go back to certain activities. But you do want to give them some time to figure out why they had it and to address any reversible issues that you might be able to fix in them. And then the desire of the athlete to continue athletic competition should not represent the primary indication for use of an ICD. So again, this idea of you only put ICDs in people because they otherwise have clinical reasons to do it. Do not put an ICD in someone just to allow them to play sports. So what are the concerns? So what are the risks? Well, there's a potential risk of sudden cardiac arrest or sudden cardiac death on the playing field. We know that usually when you're doing sports, you have elevated catecholamine levels, and there could be early reinitiation of ventricular fibrillation even if the shock is successful. So someone goes into VF, they get shocked, and then they have a beat or two of sinus rhythm, and then they go back into VF, a storm event. So that's one of the concerns of what could happen. ICDs haven't been tested in athletic conditions. So we know that someone may be acidotic, they may be febrile, they might have electrolyte abnormalities. Is the shock going to fail because of that? Will the leads or the ICD be damaged? So is there some sort of repetitive injury or repetitive sort of use concern? Are you going to break a lead over time? Is a ball going to hit the chest in some way and damage an ICD? And then is there a risk of harm from syncope or an ICD shock? So let's say you have someone who's bicycling and they pass out and they fall over and then they get shocked. Are they going to hurt themselves in that sort of situation? So in the literature, at least still that I can find, is only 2 reports of failed shocks with anyone who are even vaguely exercising. So there was a 61-year-old who had coronary disease who's on ethimazine, which don't even use anymore. I don't even know if it actually exists on the market anymore. It may have been withdrawn. And this was during a treadmill test, and the person developed VT storm. The ICD shocks were effective at first, but then failed because he was storming, and then external shocks failed. Again, this is in a treadmill test in a supervised situation. And then other one was a 49-year-old with dilated cardiomyopathy who had 8 glasses of whiskey over 3 hours, and then exercised, and that's not described what they did. And then had 8 shocks for VT, and then the episode ended spontaneously. So that's all that has been reported. Now, obviously, that doesn't mean that's all that's ever happened, but at least that's what's out there. Rachel Lampert is really the main driver in this field and has done a lot of great work. And she started back in 2006 with a survey looking at what are heart rhythm doctors allowing their athletes with ICDs to actually do. And what you can see here, I don't like a lot of the graphs that she uses, so I'm going to try and explain this here. So this is telling people to avoid activities. So not allowing them, but the opposite of avoiding. So the big one here is contact sports. So anyone who has an ICD, 80% of the time they're saying avoid contact sports. But 20% of heart rhythm doctors back in 2006 were allowing people to do contact sports. If you look at competitive sports, it was about 50-ish% or so were allowing back then. Sports with risk injury was about 65% they were allowing. And the sports that were sort of low risk were pretty frequently allowed. And if you look at what were people being more restrictive or less restrictive about, so they're more restrictive for ARVC, telling people not to do sports even if they had an ICD. A little bit more restrictive for long QT, and I'd argue that we're changing that. And then hypertrophic cardiomyopathy, coronary disease, other cardiomyopathies are really a little bit more restrictive. And less restrictive was this sort of idiopathic ventricular fibrillation. Again, sort of a difficult chart to see here, but the big message is the big sports where people were doing here was basketball, running, jogging, track, or skiing, and then a few others here. And there really were not a huge number of complications associated with this. Again, it's sort of a difficult chart to follow. But there was some lead fractures and such, but really not a huge amount of patient injuries associated with this. So one of the things about this study and about the couple other studies I'm going to show you is that they don't really get into programming of devices, and this is actually a really important thing. I'm just curious here, how many people in the audience here are electrophysiologists or follow people with ICDs and they're the primary person? So a couple, one. Okay, so we have a couple here. One of the keys, and if you're following any of these people, if you're not an electrophysiologist, is you want to be sure that the programming is done in such a way that's both age appropriate and then it's appropriate for their activity level. What you really want to do is try and maximize the chance that a shock is going to be successful while minimizing the risk of an inappropriate shock. So some of the things that could be done. So for me, I really love the subcutaneous ICD, especially for younger people. When we talk about young people, you're talking about a lifetime of complications related to leads. And you may be able to solve a problem immediately and say, okay, I'm going to put an ICD in this person. But 10 years, 15 years, 20 years down the road, if they have a transvenous ICD, how do you manage that person when that lead fails, regardless of whether they're an athlete or not? So I really like the subcutaneous ICD because that lead is really designed never to fail. There's been, as far as I know, 3 reports of lead failure of the 20 to 30,000 that have been put in. And those 3 reports is someone who sewed through the lead, another one who had there was a manufacturing error, and then the third was a twiddler who pulled the lead and pulled it so much that the lead broke. The thing about the SICD, the one issue, and Dave touched on this, is that in the hypertrophs, that's the one population I get a little bit concerned about the subcutaneous ICD. The reason is just that with exercise, there can be T-wave variation. And so with the subcutaneous ICD, it could be mistaken with getting a larger T-wave, and it could give an inappropriate shock. So I'm a little hesitant in the hypertroph population unless you've, at the very least, done an exercise test to assess for that. Or when talking about a transvenous ICD, though, one of the keys is you really want to program in longer detection times. So you want to give it more time for a non-sustained rhythm to try and actually self-terminate. We know that a lot of VT and even VF will stop on its own. So if you can give that device enough, or give the patient enough time to try and stop the rhythm on its own, you can actually prevent a shock. Or people who have sinus tachycardia, or even some SVTs, that it may allow time for that heart rate to slow down. The other thing is high rate zones. So depending on the age, you want to be sure that you're programming it that they're not going to get shocked unless they're 210 beats a minute, 220 beats a minute, even 230 in certain circumstances. You really want to make it pretty high and not like you would standardly do for your 65-year-old primary prevention cardiomyopathy patient who you might make it at 188 or 200 or whatever you're doing for your patients. We're going to talk about the ICD Sports Safety Registry because this is really the only data that exists, but it's a pretty good database. So the Sport Registry, which again Dr. Lampert did, published in 2013, the primary aim of this was to determine the safety of sports participation in those with ICDs. The initial publication had 372 participants doing some sort of organized sport, with a smattering of all the diseases that we've been talking about here. So the big ones were long QT, hypertrophic cardiomyopathy, ARVC. It did have coronary disease because there was not an upper age cutoff, and then idiopathic VF and a few others. Excuse me, they were doing a bunch of sports, again, just the ones we've been talking about: skiing and snowboarding, running, marathon, soccer, basketball, cycling, all the sports that our athletes are participating in. And overall, there were no deaths, there were no cardiac arrests, and there were no arrhythmia or shock-related injuries during sports. So that means, again, that no one passed out, fell off a bike, and got a concussion or broke their arm or something like that. All episodes of VTVF were shocked successfully by the ICD. It may have taken more than one shock, but it was always shocked during that episode of up to 6 or 8 shocks, depending on the device. There were 2 deaths in the study. One was a 52-year-old cyclist who had coronary disease, and he died at his desk after receiving multiple shocks. And the other was a 34-year-old softball player who had a familial cardiomyopathy, and she died during a heart failure hospitalization. So really, I don't think we would say either of those are sport-related. Again, I find it difficult to look at these tables here. There were a fair amount of shocks that happened during competition or practice. There were some that happened during physical activity that were not competition, so someone who's off jogging, let's say, on their own. And there were times when people had events that were not associated with activity. And it could be VT, it could be VF, but then there were also shocks for sinus tachycardia, and they were more likely to happen during sport. Or during physical activity. Some atrial arrhythmias like AFib, and other SVT. Occasionally there were for noise, although it's interesting that the noise happened more commonly not during sports. And then some T-wave oversensing and other things. What was interesting about this, the group that was most likely to have an ICD shock were those who were ARVC and idiopathic VF, and then coronary disease also. And that was much more common compared to HCM and long QT syndrome or others. And this is a group, I think, at least in my experience, I would agree with this. I think the idiopathic VFs, we tend to see this. ARVC, we've talked a lot about being most concerned about that group. And coronary disease, which we actually have not talked a lot about, but that would be another group to be concerned about. Lead malfunctions. So this is the Kaplan-Meier survival curve of leads, and this was definite or possible lead malfunction as opposed to just purely definite lead malfunction. So if you look over time, the 10-year survival rate or failure rate was about 15%, survival rate about 85% of a definite or possible lead malfunction. And there's no control group here. It's tough to say what it would have been if they weren't during sport, but I'd argue that it probably wasn't that much different. It's probably a little bit more, but I don't think it's hugely different compared to just a young population. We know that younger people are going to be more likely to get lead fractures. We know that people who have channelopathies are more likely to get lead fractures versus someone who's got a low EF. So I think this is within the reasonable range of what you'd expect for a non-athlete population. So they actually just this year published their long-term follow-up. So they had a little bit more subjects this time, 440 subjects, followed for 44 months. And again, there were no tachycardia-related deaths. There was no externally resuscitated cardiac arrests. And there was still no injury from arrhythmia, syncope, or shocks. 10% received a shock for VT or VF during sport. And there was more during sports than during rest. But it was no different, just like we were sort of talking about earlier, it was no different if it was during a match or practice versus if they were doing other activity on their own. So if they were off jogging on their own, let's say. 4% did have multiple shocks. And over a 44-month period, that's, not surprising, actually. Some of those were doing either competition practice or some sort of physical activity. 5% had an inappropriate shock during sport. And again, that same sort of Kaplan-Meier survival curve of the leads, about 15% failure rate at 10 years or so. So I think my take home from this is actually really reassuring. These are people who were doing these activities anyway. There were no deaths. That's the biggest thing. There were no deaths, and there was no physical harm to the patient, like a broken bone or concussion or something related to this. We've spent a fair amount of time talking about long QT related issues. I think Mike Ackerman talked about some of these things of the his experience with the long QT syndrome. He talked about his one was it 11-year-old, I think, with long QT who's now had 3 shocks. As his only one. There have been a couple other studies that have looked at this, but they're pretty small populations. So this was a group of long QT syndrome doing sports, and this you can see just that there were 6 that had ICDs, and they all did okay. And then there's also another paper that came out this year, and this was a group, there was, again, sort of a little difficult to follow here, but there were 27 with long QT syndrome and ICDs in this group. And if you look at the group that had some sort of cardiac arrest or cardiac event during recreational activity, only one of those, or this would also be sports, only one of those actually had an ICD shock. So there were 3 others who had long QT who actually had an event and had to have an ICD implanted. And then there were a bunch of those who had a shock during just their general activities of daily living, which of course has nothing to do with sports. We spent a lot of time talking about this. I'm not going to get into it too much. I'll sort of try and breeze through a little bit, but just the idea of whether to allow a patient to go back or not to sports. So we know that with adolescents with ICDs, there are a lot of psychosocial issues, but the number 2 reason is they're worried about being restricted. They really love to do sports and love to do activities, and they don't want to feel different than their peers. Just another study looking at, or a couple studies looking at quality of life with sports, really we know that restriction from sports does reduce quality of life, and it's really one of the most challenging issues for these patients of living with an ICD is being restricted. There can also be this anxiety about shocks. I think anybody who follows anyone with an ICD who's ever been shocked once is always worried about another shock. But for some people, there's actually a reassurance that they have the ICD so that if something life-threatening does happen, that the shock will get them out of it. And again, it's just this idea of educating patients, having really long conversations with them, trying to recognize that patient-athlete autonomy, educating the patients about the risks, and we're talking about risks of both appropriate and inappropriate shocks. Some of the discussion about lead failure. I do worry just, again, that there is this slightly increased risk associated with sports. Trying to make sure that the person is on their optimal medical therapy for whatever their disease is, whether it's a beta blocker or something else. And then trying to avoid some of the triggers. So depending on the underlying disease and sport, dehydration, you want to avoid electrolytes, you want to watch out for fever, especially if it's a Brugada patient. And then again, appropriate ICD programming. So overall, we know that many patients are participating in sports with ICDs. There really is this importance of the appropriate medical therapy for them. ICD shocks may happen. We want to program those devices appropriately. And then one of the questions is, do you tell people to avoid certain types of sports? And I didn't get into this too much, but do you allow a football player who's going to be hit really hard to play? Do you allow someone to go skydiving or scuba diving? Well, scuba we can't, but and I would argue that you probably want to avoid at least certain sports. So it's really a thorough discussion, and it really comes down to patient autonomy for me. And the question is, do you allow the patient to make an educated decision even if it's against your medical advice? So thank you.